Alright, hi everyone, how are we all doing? Today we'll be talking about the ligamentous anatomy of the shoulder. So the shoulder is one of two places in the body where we'll find a ball and socket joint, and as such the shoulder has considerable levels of mobility and a large variety of ligaments acting upon the humerus, scapula, clavicle, and sternum. The ligaments of the shoulder are located within the glenohumeral joint, the acromioclavicular joint, and the sternoclavicular joint. First up, we'll be talking about the sternoclavicular ligaments. While these ligaments are not located directly within the shoulder joint capsule, they're still a big part of overall shoulder joint anatomy as they contribute to shoulder function and stability. Now, if you'll take a look at the bottom right picture on page 1 of your handout, you'll find these ligaments. And the first one we're going to be talking about is the anterior sternoclavicular ligament. It originates at the medial end of the clavicle and inserts at the anterosuperior manubrium on the sternum. It functions to limit superior displacement, resist upward rotation, and resist lateral movement of the clavicle. Next is the posterior sternoclavicular ligament. It originates on the posterior surface of the sternal end of the clavicle and inserts on the posterosuperior manubrium. This ligament resists downward rotation and medial movement of the clavicle. The costoclavicular ligament originates on the superior surface of the first rib and its cartilage and inserts at the costal tuberosity on the inferior medial aspect of the clavicle. Its function is to limit elevation of the shoulder girdle and clavicle as well as limit antero-posterior movement at the sternoclavicular joint. Finally, the interclavicular ligament. It originates at the upper part of the sternal end of one clavicle and inserts at the upper part of the sternal end of the other clavicle. It functions to resist excessive downward glide and clavicular dislocation with shoulder depression. Moving on, now we'll be talking about the glenohumeral ligaments, and the first one we encounter is the superior glenohumeral ligament. It originates at the apex of the glenoid fossa near the root of the coracoid process, and inserts at the upper portion of the lesser tubercle of the humerus. This ligament stabilizes the bicep brachii tendon and limits external rotation during adduction. The inferior glenohumeral ligament originates at the inferior edge of the glenoid fossa and inserts at the anatomical neck of the humerus just above the lesser tubercle. This is the main shoulder stabilizer during abduction. It also restrains anterior and inferior translation of the humerus. Next up is the middle glenohumeral ligament. It originates at the medial edge of the glenoid fossa and inserts at the lower part of the lesser tubercle of the humerus. Its function is to provide anterosuperior stability and restrain external rotation from 0 to 90 degrees of abduction. Lastly is a ligament that not everyone actually has, the spiral glenohumeral ligament. It originates at the infraglenoid tubercle and inserts at the lesser tubercle of the humerus with the subscapularis tendon. It functions to stabilize the shoulder during external rotation and abduction and also prevents excessive anterior translation of the humeral head.
So the next shoulder ligament is the coracoid-humeral ligament. The superior band originates at the lateral border of the base of the coracoid process, and its inferior band originates at the lateral surface of the base of the coracoid process. So the superior band inserts at the greater tubercle of the humerus with the supraspinatus tendon, and the inferior band inserts at the lesser tubercle of the humerus. So its function and kinematics is that it reinforces and strengthens the upper part of the glenohumeral joint capsule, and it helps in protecting the head of the humerus. So the next ligament is the acromioclavicular ligament. The superior part originates at the superior surface of the acromion, and its inferior part originates at the inferior surface of the acromion. So its superior part inserts at the lateral end of the clavicle, and its inferior part inserts at the lateral end of the clavicle. So its function and kinematics is that it reinforces the superior portion of the joint capsule and provides horizontal stability at the AC joint. The next ligament is the coracoid-clavicular ligament. So its coinoid ligament originates at the posterior surface and root of the coracoid process of the scapula, and its trapezoid ligament originates at the superior surface of the coracoid process. So the coinoid ligament inserts at the coinoid tubercle on the inferior surface of the clavicle, and the trapezoid ligament inserts at the trapezoid line on the undersurface of the lateral clavicle. So its function in kinematics is that the coracoid-clavicular ligament is extremely strong. It carries a large load and keeps the scapula attached to the clavicle. So it provides vertical stability at the AC joint, and it transmits weight from the upper limb to the axial skeleton. So the next ligament is the coracoid-acromial ligament. So it originates at the lateral border of the coracoid process, and it inserts at the inferior anterior lateral surface of the acromion. So its function in kinematics is that it protects the head of the humerus, and it increases shoulder stability and prevents superior dislocation of the glenohumeral joint. So it also transmits loads across the scapula. So the last shoulder ligament is the transverse humeral ligament. So it originates at the greater tubercle of the humerus, and it inserts at the lesser tubercle of the humerus. So the function in kinematics is that the transverse humeral ligament holds the long head of the biceps tendon into position in the intertubercular groove. So here are some fun facts about the shoulder ligaments. So fun fact number 1 is that the 4 glenohumeral ligaments are not seen in everyone. So starting from the superior glenohumeral ligament, it is only present in 98% of the population. The inferior glenohumeral ligament is only present in 94% of the population. So the medial glenohumeral ligament is only seen in 88% of the population, and the spiral glenohumeral ligament is the least commonly seen glenohumeral ligament in the population and is only found present in 45% of the population. So fun fact number 2 is that the coracoid-clavicular ligament helps to keep the attachment of the scapula, which actually gives the square shape to the shoulders.
So now I'll be talking about the kinematics of the shoulder joint a little bit. So the shoulder joint is a highly mobile ball and socket joint that allows for a wide range of movements in multiple planes, including flexion, extension, abduction, adduction, internal rotation, external rotation, and circumduction. The shoulder joint's remarkable mobility enables various activities such as reaching, lifting, throwing, and swinging, but it also makes it especially susceptible to instability and injuries. Here are a few common shoulder injuries. Rotator cuff tear. Athletes are particularly susceptible to rotator cuff injuries. Baseball and tennis players are especially susceptible to overuse tears as they're constantly putting their shoulders through intense stress. Painters, carpenters, and others that do a lot of overhead work are also at an elevated risk, especially as we age. Next up is a labrum tear, an injury to the ring of cartilage within the joint. Some of the more common tears are known as a slap tear and a Bankart tear, and the Bankart is especially known to increase risk for further shoulder dislocations. Next up is impingement. So impingement syndrome results from the irritation, degradation, and inflammation of anatomical structures within the shoulder. In primary impingement, the subacromial space is structurally more narrow than a healthy one. And in secondary cases, the patient's anatomy is normal at rest, but impingement begins to occur once the shoulder joint starts moving. And finally, frozen shoulder. As you may have guessed from the name, frozen shoulder is extreme stiffness of the shoulder, most often developing between the ages of 40 and 60, although it can happen at any age. This is prone to developing following an injury. If kept immobile for too long, the developing scar tissue can restrict flexibility and further increase risk of injury. That's it. Thanks for listening, everyone.